Dr. Wilmer G. HECETA Memorial Lecture. And let's welcome for today our Master of Ceremony, Dr. Rodney Jimenez. To start the program, let us begin with a word of prayer, followed by the national anthem by the chorus melodies.
Now let's hear some opening remarks from our Dean of College of Medicine, Dr. Norbert Lingling Uy.
Warm greetings to everyone attending the 8th Dr. Wilmer G. HECETA Memorial Lecture. Once again today, we honor the memory of the man who led his class in 1961 to start making UERM College of Medicine one of the top medical schools in the Philippines. Dr. HECETA graduated cum laude, and 89% of his batch passed the board examination that year. Their batch set the standards that our graduates must perform in the subsequent licensure examinations. For the past 65 years, our dedicated faculty and committed administration have relentlessly pursued the goal of excellence. To date, among all medical schools in the Philippines, UERM ranks second to UST in terms of new doctors produced and the number of board exam passers. Leading comparison portals list our school as one of the top 10 medical schools in the country. Dr. HECETA was among the trailblazers of UERM graduates, occupying essential positions in hospitals in the United States of America. Despite his success in the USA, he never forgot his alma mater. He established the 333 Endowment Fund movement that rallied our alumni in the United States of America to support worthwhile programs of our school. This legacy of Dr. HECETA continues up to now. Our commemoration of his memory this year with a lecture on the management of heart failure by an alumnus who likewise had an excellent medical career in the United States and is equally benevolent and generous is most fitting. Dr. Benjamin Lumicao is a batchmate of Dr. HECETA and attained an illustrious career as a cardiologist in Chicago. His commitment to helping us with our Study Now, Pay Later program gave impetus to the overwhelming support of our alumni in America for the project. As Dr. Lumicao discusses the management of heart failure today, he brings new hopes and a brighter future to people encumbered in their lives with obstacles that seem to be ominous. The topic of the lecture befits the season, and we are very eager to listen to the talk. We are grateful to Dr. Samuel Irastorza, the president of the UERM MMCI College of Medicine Alumni Association, Drs. Randy Puno and Dr. Elmer Hilo, the presidents of Medical Alumni Association in America and Alumni Foundation in the United States, respectively, and their officers, and Dr. Abigail Rivera and the members of her committee on special conferences for making this year's Dr. Wilmer HECETA Memorial Lecture possible. Thank you, and I wish all a very fruitful night.
Now let's watch a tribute video for Dr. Wilmer HECETA.
Parang kailan lang ang mga pangarap ko'y kay hirap abutin. Dahil sa inyo, napunta ako sa aking nais marating. Nais ko kayong pasalamatan kahit man lamang isang awitin. Parang kailan lang halos ako ay magpalimos sa lansangan. Dahil sa inyo, ang aking tiyan at ang bulsa'y nagkalaman. Kaya't itong awiting aking inaawit, nais ko'y kayo ang handugan. Tatanda at lilipas rin ako, ngunit mayroong awiting iiwanan sa inyong alaala. Dahil minsan tayo'y nagkasama. Parang kailan lang ang mga awitin ko ay ayaw pakinggan. Dahil sa inyo, narinig ang isip ko at naintindihan. Dahil dito'y ibig ko kayong ituring na matalik kong kaibigan. Tatanda at lilipas rin ako, ngunit mayroong awiting iiwanan sa inyong alaala. Dahil minsan tayo'y nagkasama. Tatanda at lilipas rin ako, ngunit mayroong awiting iiwanan sa inyong alaala. Dahil minsan tayo'y nagkasama. Tatanda at lilipas rin ako, ngunit mayroong awiting iiwanan sa inyong alaala. Dahil minsan tayo'y nagkasama.
So let's now go to the heart of the matter. But before that, I will introduce to you the person who will introduce our speaker for today. So Dr. Chua is also a graduate of the UERM College of Medicine of class of 1962. He was formerly the Chief of Cardiology in the Scott Air Force Base in Illinois, Clark Air Force Base in the Philippines, and the Travis Air Force Base, California. He was also the co-director of the Cardiac Catheterization Laboratory, David Grant USAF Medical Center, Travis Air Force Base, and then he was a cardiologist and flight surgeon in the US Air Force, where he is a retired colonel. Dr. Chu was also a former instructor in medicine in the University of Illinois and a clinical assistant professor of medicine in the University of California, Davis. Dr. Chu was a former president of the Philippine Medical Association in Chicago. He is also a member of the Philippine Board of Medicine and the American Board of Internal Medicine, and is also board certified in the cardiovascular disease at the ABIM. He is a fellow of the Philippine College of Physicians, the American College of Physicians, and the American College of Cardiology. So to introduce our memorial lecturer, let us give the virtual floor to a fellow alumnus and an esteemed colleague, Dr. Ernesto Chua. Take it away, Dr. Chua.
Thank you very much, Dr. Jimenez. President of UERMMC, Dr. Esther Garcia, Dean of the College of Medicine, Dr. Norbert Lingling Uy, Dr. Esterbel Hecetta, Dr. Benjamin Lumicao, Dr. Abigail Rivera, Dr. Rodney Jimenez, fellow medical alumni, ladies and gentlemen, I'm humbly honored to introduce the speaker in this year's Wilmer G. HECETA Memorial Lecture. And especially, I feel privileged and delighted that I have known our speaker for so many years as a fellow student, as a fellow alumni, as a fellow physician in Chicago, as a role model, and as a respected colleague. It is said that the best way to predict the future is to invent it. And our speaker started inventing his future when he was a medical student, as a very active student leader. He accomplished so many things, highlighted by his being president of his class, president of the Student Council of the College of Medicine, and one of the leaders and founders of the Mu Sigma Journal Club, an academic organization of class 1961. At this point, I'd like to say with pride and with gratitude that I was among the 3 students from class 1962 who were inducted into that academic club of class 1961 after screening, interview, and a sponsorship by founding members. And I fondly remember one of my sponsors was a young, handsome medical student, active student leader, very fair, very friendly, had a full head of hair, popularly known on the campus as Ben. Our speaker had his training in internal medicine and cardiology in 2 of the most prestigious institutions in the United States, namely Northwestern University and University of Alabama in Birmingham. After his training, he went on to distinguish himself as an astute clinician, a very erudite teacher, a dedicated mentor, leader of several professional organizations, a devoted family man, and an inspiration and a lodestar to many medical students and young physicians. Our speaker is board certified in internal medicine, board certified in cardiology, a professor of medicine, and a fellow of the American College of Cardiology, a fellow of the American College of Physicians, and a fellow of the Chicago Institute of Medicine. Because of his many accomplishments, he has been given awards by various organizations, among them the Outstanding Teacher Award from Northwestern University, the Distinguished Physician of the Year Award of the Philippine Medical Association in Chicago, and the Distinguished Alumnus in Medical Education Award of UERMMC. Additionally, he had been chosen as a speaker at the Dean Jose Cuyag King Memorial Lecture Series. It would be logical to presume that with his accomplishments and recognition and his becoming an octogenarian, that he would be retired and enjoying his retirement. But that's not the case. Our speaker has kept himself busy to the benefit of many of us. Recently, for instance, he authored 2 books. One entitled The Odyssey of a Foreign Medical Graduate. The other book is about a love story straight from the cardiologist's heart. And he is also presently provost of the St. James Medical School. Now, how about that? Makes me think that his initial of BGL means born to guide and lead. So with pride and respect, I present to you the distinguished, admired, and tireless Dr. Benjamin G. Lumicao. Thank you.
Thank you very much, Ernie, for your very kind and generous comments. I thought we agreed that you were going to make it just a brief comment. But again, I want to thank you very much for agreeing to introduce me. I feel honored for you doing so.
Thanks.
Thank you, Ernie. So tonight, I'd like to greet Dr. Lucio Tan, Chairman of the Board, Wilson Young, Vice Chairman, President of the Medical Center, Esther Garcia, our own Dean, Dr. Norbert Lingling Uy, the Chairman of Academic Affairs, Gemiliano Aligi, the various deans, and members of the House staff, fellows and residents and students. And special thanks to the committee responsible for tonight's affair. I specifically would like to honor Abigail Rivera, who I've had frequent contacts to make sure that this will do well. And of course, Rodney Jimenez, who's the one responsible for the flow of this meeting tonight. I am especially thankful that they were able to find a picture that is in the program, which reminds me that at one time, Ernie, I had a full head of black hair. So it is indeed a great honor to present the Wilmer HECETA Memorial Lecture. It is a great pleasure for me because he is a personal friend, a very dear friend. That friendship started during our school days and it continued on as we both came to the United States. As a matter of fact, we traveled together. We took the Panam flight from Manila to the United States together. Let me have the first slide, please. This is Wilmer HECETA wearing his toga as a fellow of the American College of Surgeons. Wilmer has a very strong personality, and as you can see in the next slide, he looks every bit like a chairman of the board. And he was chairman of the board of the UERMMMC Foundation for a long time. He was a founding chairman, by the way. Next slide, please. You have already listed his academic accomplishments and all that. And I'll just want to mention that he's board certified in general surgery, board certified in cardiothoracic surgery, and he was a fellow of the American College of Surgeons. But with all these accomplishments, awards, citations, and all that, Wilmer's priority in life was really his love and devotion to his family. We go back a little bit, one slide, just to show you the picture of the woman Wilmer adored, rather. That's Esther Bella Aguilar, our classmate, who herself is a very accomplished lady. Next slide. They were blessed with 3 daughters. Christina on the left, who is an MBA, Elgin on the right, who is a lawyer, and Wella who has a Bachelor of Arts degree. Next slide, please. He enjoyed the family vacations. Go back. Like this one. Wilmer also has another family, the Class 61 family. And all members of Class 61 admire and respect him. But we know him better for his warmth and good humor. Let's show the next two slides. This is the Wilmer that we know, having fun. And the next slide, showing his muscles. This is how he behaves when we are all together. And with this last slide, I now would like to proceed with my formal lecture on congestive heart failure. Next slide, please. Let's go back to the first slide. Next slide. So the topic is congestive heart failure with emphasis on reduced ejection fraction. Next slide. Next slide. The old definition of heart failure is the condition where there is inability of the heart to meet the metabolic needs of the body. The better definition is that the heart failure is a clinical syndrome with symptoms or signs of structural or functional cardiac abnormality, corroborated by elevated natriuretic peptide levels and/or objective evidence of pulmonary or systemic congestion. Next slide, please. This is the extent of the problem. At least in the United States, we can say that 1 million of CHF hospitalization per year at a tremendous cost of $40 billion. It is the most common ICD diagnosis for patients older than 65. But what is even more disturbing is that 1/4 of these patients die within 1 year, 50%, half of them within 5 years. Next slide, please. There are, of course, many causes of congestive heart failure. Most important in this country, of course, is coronary artery disease with myocardial infarction, myocardial ischemia, pressure overload with hypertension, obstructive valvular disease, ASMS, chronic volume overload with regurgitant valvular disease, AIMRTR, and in present conditions now, we see patients with congestive heart failure due to COVID-19. Next slide. It can also be pulmonary causes and other metabolic causes. We don't see very anymore. So heart failure has been divided into, next slide, with reduced ejection fraction or preserved ejection fraction using -40 or equal to -40% and greater than 45 for preserved. My talk will be confined to reduced heart failure, where we see the most of the benefits from the interventions that we employ. Next slide, please. Well, this is the New York Heart Association, which you're all familiar with, and this is going to be what will be used in all the studies that I'm going to review. An easy way to remember class 1 is to call it asymptomatic, class 2, symptomatic with moderate exertion, class 3 with symptomatic with minimal exertion, and class 4 symptomatic at rest. Next slide, please. Actually, the whole basis of our understanding of the therapeutic approaches to congestive heart failure has been based on the neurohormonal and sympathetic system. And as you can see here, there's a quick review of the RAAA system, where angiotensinogen is produced by the liver. It is acted upon by renin to produce angiotensin 1. ACE leads to the production of angiotensin 2, which is a very potent vasoconstrictor, but it also stimulates the adrenal gland to produce aldosterone with water retention and aggravating the congestive heart failure. Next slide. Next slide, please. This is a schematic representation of what I just went through. And as you can see, the areas of inhibition will be the basis of our management for congestive heart failure. There was a drug called the renin inhibitors called Tecturna. It is interesting that in medicine, you see, well, sometimes it's logical perhaps to say that if you block it at the renin, the following interventions may not be necessary. But that's the beauty of medicine, you know. The proof is in the pudding. And there's a drug called Tectura that was a renin inhibitor that didn't work. So actually, the areas where we institute intervention would be the ACE inhibitors, the angiotensin 2 receptor blocker, and of course, the use of aldosterone receptor antagonists. And I'm now going to go through all these studies that are involved in the management of congestive heart failure. Next slide, please. Well, the first attempt in improving congestive heart failure was the use of vasodilation therapy, LV unloading. This was the VF1 as early as 1981, New England Journal of Medicine, which compared isosorbate dinitrate hydralazine with prazosin. And as you can see, there is 34% reduction in isosorbal and hydralazine combination. Next slide. Next slide came the use of ACE inhibitors. And this was the SOLVE study, studies on New York Heart 2 and 3, a ejection fraction of 35% or less, and comparing enalapril to placebo. And after 2 years, the mortality benefit of 16%. Next slide, please. And it was, of course, reasonable to compare the new enalapril to what I mentioned earlier, the vasodilator therapy. And obviously, there was better benefit with enalapril. Next slide. This is the study that actually established ACE inhibitors as the drug for congestive heart failure. This was consensus 1. It dealt with class 4 severe congestive heart failure. Look at that. There were only 253 patients. But look at the results. There was 40% reduction in mortality, almost half in 6 months. 31% reduction in mortality in 1 year. And there was improvement in New York Heart Association. So the trial was stopped early. Next slide. ACE inhibitors were also used in post-MI cases. We have the SAVE study with captopril, ARI with ramipril. Next slide. Oh, forget that. Next slide. And TRACE study with randalapril. And as you can see, there was again improvement with the use of all this in all these 3 studies. There was one negative study, and that's the consensus 2, with the use of the IV form of enapril, enaprilat. But it was associated with hypotension and increased mortality. This was the only negative result with ACE inhibitors. So the lesson was, don't give it IV and wait a few days. Next slide, please. And this is the graphic representation of the benefit of ACE inhibitors. The top is ACE inhibitor. This is a mortality, the benefit. The top is placebo, and this is the ACE inhibitor, so the mortality benefit is there. So the cumulative mortality, similar results. Next slide, please. Now the ARBs are, of course, used. This is the CANDISART and the CHARM study. There were 2 parts to this study. One was CANDISART and used alone, which is this one, the top one, and one in combination with ACE inhibitors. What's interesting is that if you use candesartan, use it alone. Don't use it in combination with ACE inhibitors, because you have better results by using it alone. Next slide, please. Now we go to beta blockers. I mentioned earlier that in terms of the renin inhibitors, it looked logical, and that you would think that if you block it on the top, it would follow down the lower inhibitory systems would not be necessary. Here we have, again, something that's very interesting. We are dealing with patients with reduced ejection fraction. Why should we be using beta blockers, which further reduce contractility? Yeah, it's counterintuitive. And it took the guts of an English investigator to use beta blockers. I'm sure that if Ernie and I, during our school days, would use beta blockers, they'll probably throw us out of UERM because it would be crazy. But that's the beauty of medicine. These studies now that I'm going to go through will show you that beta blockers in congestive heart failure are one of the mainstays in the management of congestive heart failure. Go back. Yep. The first one is the MERIT trial with metoprolol succinate. And as you can see, there were class 2 and 4 patients with mortality reduction of 34%, sudden death 44%, and improvement in New York Heart Association. Next would be the European study. Next slide, please. The CIBIS trial with bisoprolol as a beta that was conducted in Europe. This time there were sicker patients, 3 and 4, with EF 34%. And you see the mortality reduction 35%, hospitalization 36%, sudden death 42%. Next slide, please. The COMET study, this time with carvedilol tartrate. There was a little controversy here because they used tartrate, which is a short-acting, and perhaps the dose was small. Nonetheless, I think carvedilol definitely was shown to be a better drug with all-cause mortality of 34%, while metoprolol tartrate was 40%. Next slide. Copernicus, patients with severe heart failure. Look at the ejection fraction of 25%, class 3 and 4. There's a 35% reduction in mortality. It's going to be monotonous. I mean, in terms of beta blockers, it's mid-30s was the benefit. Next slide. Capricorn, it was also used in the post-MI patients. And again, there's a reduction in mortality in these patients. Next slide. Now, don't be confused with this one because the top one is mortality. The lower one is survival. And that's the MERIT trial, shows the benefit with beta blockers. In terms of survival is improved with CIBIS and Copernicus. Next slide, please. How about aldosterone receptor antagonists? Now, the seminal study was done by Dr. Bertram Pitt from Michigan, the RALS study, with the use of spironolactone, comparing it to placebo. In sick patients, class 3 and 4, ejection fraction less than 35%. This was an early study, so there was very little use of ACE inhibitors and no use at all of beta blockers. But look at the results. Mortality was reduced 30%, sudden death 30%, reduced hospitalization significantly reduced also. Next slide. This was a purer form of aldosterone receptor antagonist, eplerenone. So this was used in the Ephesus study. And again, there was a significant mortality reduction. There was also a reduction in sudden death. Next slide. This is the emphasis study again with eplerenone. It was a 21-month study with, again, significant reduction in cardiovascular death and mortality. Next slide. This is emphasis. Next slide. So This is a graphic representation showing the survival this time, and mortality. It's just the opposite of the earlier graph that I showed, showing a better survival with spironolactone, better mortality statistics with eplerenone. Next slide, please. Now, how about the use of digitalis? Whenever we have patients with congestive heart failure, pop, automatically, digitalis, of course, you should use it. Here are 3 studies, Regents, Proved, and DIDS trial. Surprisingly, no survival benefit. The p-value was 0.06. It didn't quite make it. But we learned that if you withdraw the digitalis, they stay longer in the hospital, and it prevents more longer hospitalization stay. But again, I want to emphasize that there's no survival benefit with digitalis. As a matter of fact, the British usually don't even use it for congestive heart failure, which is very interesting. But it's a habit that we do now, and it helps. If it keeps you out of the hospital, shortens the stay at the hospital, then you should use digitalis, but you should be careful. Next slide. This is the paradigm trial with angiotensin neprilysin inhibitor, comparing it with enalapril. Again, there was a slight controversy again here because maybe the dose of enalapril was not big enough. But if you review the earlier studies that we had in terms of ACE inhibitors, this was the dose that was used, just 10 milligrams BID. And indeed, there's a further reduction in cardiovascular death of 20% with the use of neprilysin compared to enalapril. It was approved by the FDA in July 2025 and is now recommended by the ACC and AHA as a drug that should be used in congestive heart failure. Next slide, please. Oh, these are the mechanisms why it works. You have actually, the drug is a combination of sacubitril and valsartan, and these are the beneficial effects of valsartan to the left and the 2 beneficial effects of sacubitril on the right side. Now you know why valsartan was chosen instead of an ACE inhibitor in combination with sacubitril. Because if you had the ACE inhibitors, your bradykinin levels would be very, very high, and that's probably would invite more side effects or even problems like we saw with enalapril. Next slide, please. I put this slide in just for completeness sake. In the United States, for the African Americans, for patients that are already on contemporary therapy, ACE, ARB 87%, almost 90%, beta blockers 75%, spironolactone 40%. If you add the vasodilators, hydralazine and isodil, you still see a significant separation of survival separation among Black patients. This is unique for African Americans. Next slide, please. Now we get now into the new innovations in the treatment of congestive heart failure. This is the SHIFT trial with ivabradine, trade name of Corlanor. The mechanism of action is that it inhibits the so-called F channel in the sinus node. There are situations that we have in practice where we use the ACE inhibitors, and despite a big dose of beta blockers, despite the big doses that we use, there is still tachycardia greater than 70%, which of course is deleterious because it increases autoconsumption. This drug is a blessing because it slows down the heart rate by working on the sinus node. But of course, it's very important that the sinus node be still functional for it to function. So The relative reduction with the use of this drug is 18%, which is pretty good. Next slide, please. Now let's go to the use of SGLT2 inhibitors. This is a fascinating drug. As Ernie knows, there's a lot of noise going on in this, and I'll be making my comments at the end of this presentation, to end this presentation rather. This is very interesting with the use of empagliflozin initially for diabetes. They found out that there were patients who were out of congestive heart failure or improved with congestive heart failure. So this was investigated further. So this is now the Emperor reduced trial. Yeah, we don't know the mechanism, which is another interesting. There's a lot of theories why it works, but we actually don't know the actual mechanism. But what's important is that it works, and here are the results. Ejection fraction less than 40%, primary outcome composite of cardiovascular death or hospitalization. And look at the p-value, 0.001, with relative risk reduction of 35%. It is amazing. Yeah. But what's even more important is that the results are there irrespective of whether that patient has diabetes or not. This is the interesting point about it. I'll be going back to this later on. But there's another benefit. It's the annual decline in GFR with this drug. Next slide, please. And this is a graphic representation that actually you can easily see the separation of the two graphs with the use of empagliflozin. Next slide, please. Another innovation is the Victoria study with vericiguat. This drug vericiguat is now commercially available in the United States. I don't know whether it's still available in the United States. This is an interesting drug because it helps generate cGMP, which is the necessary for the metabolism of the myocardium. So this is a study on class 2, 3, and 4 with ejection fraction of less than 45%. You may, looking at this vericiguat, 35.5, placebo at 38.5, you might say, that's not a significant separation. But the p-value is 0.02. And don't forget that this is a later study, and contemporary drugs, ACE inhibitors, beta blockers, and aldosterone receptor antagonists were used already in this drug. So next slide. So the separation is indeed narrow, but like I said, it's a significant p-value of 0.02. Next slide. To me, this is the most exciting. Well, let's go back. To me, this is the most exciting new development in congestive heart failure. The Galactic Heart study using omecamtiv mecarbil in systolic heart failure. This was used in class 2, 3, and 4, ejection fraction less than 35%. Again, if you look at the patients and the patients group and the results, they seem to be narrow again, 37.9, 39.9. But the p-value again is 0.03. But what is very important is that with the use of these drugs, there was improvement in LV systolic ejection time, which is a measure of contractility. There was an increase in stroke volume, decrease in systolic volume, decrease in diastolic volume, which suggests improved remodeling. And there was significant decrease in plasma natriuretic peptide levels and decrease in heart rate. Next is a graphic representation in cartoon on how it works. Apparently, omecamtiv mecarbil attaches itself to the head of, as you can see here, and brings it down into the actin filament. If you look at letter B, there are only 3 heads connected to the filament. And after with the carbyl, you double it. So there is a greater contractility, greater pulling effect, so to speak, to improve myocardial function. So what is interesting about this drug is that it has nothing to do with the neurohormonal or sympathetic system. It attacks the very problem of reduced ejection fraction. It acts on the basic myocardial tissue, the sarcomere, which makes it function more effectively, as I can show in this cartoon. Next slide, please. I apologize for this slide. It's my attempt to show the mechanisms of action. On the left side is your angiotensin system. On the right side is your beta blockers, and now ivabradine and GMP. Let's go to the next slide. I'm embarrassed to show this. So with all the discussion I have now, this is supposed to be how we should treat heart failure with reduced EF. We should use renin-angiotensin inhibition, neprilysin inhibition. So these two are part of the RAA system. So we talk about 4 pillars. A and B can be grouped together, although because of the paradigm trial with a 20% improvement over ACE and ARB, the neprilysin inhibition should be the preferred form of treatment. And of course, SNS inhibition with beta blockers, SGLT2 inhibition. It's an amazing development, and I'll be going back to that. And of course, the use of aldosterone inhibition. We have ivabradine. We have the use of vericiguat, but it's not yet in the form that we should put as pillars in the management of congestive heart failure. Next slide, please. I've talked about the medications that we can employ. Device treatment is also important. Patients with wide QRS, left bundle branch block, and still normal sinus rhythm with an ejection fraction less than 35%. Use the device, you can see the difference there, a relative risk reduction of 37%. The use of defibrillators in MADIT and SCD, HF post-MI, comparing it to amiodarone shows some benefits. So device therapy is also essential and it's important. Next slide. And if everything fails, well, the last result is transplantation. And we use a temporizing device with so-called LVAD devices. Yep. And if everything fails, like I said, we go to transplantation. This is my last slide, and I want to emphasize that when I submitted this as my lecture for tonight, the literature indicated to us that all the things that I reviewed for you are all in reduced ejection fraction. But just to show you that the march of medicine is rapid, I want to talk about the I now want to talk about the emperor preserved trial. This is very interesting because this was published only last October 14 of this year. The Society of the American Society for Heart Failure met just 3 weeks ago with big leaders like Clyde Chansey, who was the chairman of the writing committee of the ACC, Milton Packer, all the big ones there. There's a paradigm shift as a result of Emperor Preserved trial. They also were influenced by the Paradigm HF, Paragon HF, and they reviewed the top cut top cut was an international study. The American cohort showed definite benefit. The European cohort did not show any benefit, but they went back and looked, analyzed them. There were no metabolites in many of the patients among the Europeans. So either they did take the drug or the drug that they were taking was not enough. So the thought leaders now, in cardiology, with specific attention to heart failure, the ones who authored the guidelines in 2017 and emphasized reduced ejection fraction. There's a change of heart now. As a matter of fact, Dr. Clancy, let's go back to slide number 40. Can we go back to slide number 40? The one that back, here. No, here. No, not this one, the next one. Yeah, this slide, Dr. Clancy, who I said was chairman of the committee that wrote the AHA ACC guidelines, is now reversing himself. He said that maybe we should throw away the artificial, division of reduced and preserved because of the effect of the drug, which is very similar. There was 21% reduction in mortality and 29% in terms of hospitalization with the use of this drug on patients with ejection fraction as high as 60. So there's a change of heart among them. So Dr. Clancy now says, these are the four pillars of in the management of congestive heart failure. You should use neprilysin or ACE inhibitors, SGLT2, beta blockers, aldosterone, regardless of the EF. Think about that. And he now proposes that there should be a polypill, one pill to include all four. So this is the march of medicine. I mean, that's what's nice about medicine. There's continued development, improvement in our education, improvement in investigation, technology, and all that. So, ladies and gentlemen, you have not heard from me the last word on congestive heart failure. Thank you.
Thank you very much, Dr. Lumicao. Okay, thank you again, Dr. Ben Lumicao, on that very elegant and comprehensive talk on the management of heart failure with reduced ejection fraction. And he also tackled a bit of the patients with heart failure with preserved ejection fraction.
Yeah.
So for me as a cardiologist, also it was really a good review for me, the history of the management of heart failure. Dr. Lumicao, I have read that a certain Dr. Stuart Bartle, a psychiatrist, is the one who invented the ejection fraction. It was introduced, I guess, in 1965 in one of the ACC meetings. Yes, okay. And the cardiologists went crazy on this ejection fraction.
Yeah.
So right now, with the advent of the SGLT2 inhibitor, as regardless of the ejection fraction, would you think that delineating heart failure with ejection fraction is still a good thing?
Well, like I said, I think the next guideline, the people in the Heart Failure Society are big people. I mean, Clancy is the chairman of cardiology at Northwestern. He's a very big. He's the one. He's the number one voice on heart failure. He makes big comments. So I think when Milton Packer also is a big. Milton Packer during the just 3 weeks ago said, count me out now in terms of ejection fraction. So, but let's wait and see. But like I said, it's not only the emperor preserved. If you look back, Even
cut.
the top cut already suggested that there is an improvement with prescription. So yeah, but
Yeah,
unless, but I kind of object to the poly pill, because I mean, uh, there are always contraindications to every pill that you use, and if you put it there and you just
I
give it to
know.
the patient,
Yes.
I think you have to yeah, a guided therapy is still important. Yeah.
Yeah. Okay, let me remind our audience that you can ask questions by raising your hands, virtual hands, and or also you can type in your questions with regard to the HEFREP and also anything about heart failure. Dr. Lumicao will try to answer those, even if it's about the heart failure on preserved ejection fraction. I have another question here. So in some of the studies I have read, Dr. Lumicao, in the advent of angiotensin neprilysin inhibitors, do you think ACE inhibitors and the ARB still have a role or still have
Oh
role?
yes, oh yes. Actually, in terms of the usage, that's the big problem with neprelation. It's supposed to be 20% better than ACE inhibitors, but
Yeah.
if you look at the use of neprelation, it's very low because it's expensive. Expensive.
Yeah. Yeah.
ACE inhibitors are still used a lot. Yeah.
Okay. Now wait. I have another.
Ernie, do you have the same impression? Is
Can we
Ernie
have
muted?
also Dr. Ernie here
Ernie?
to
No,
participate?
I don't have any question. I have a special interest in the CRT and cardiac resynchronization therapy. We have found it very useful as long as we meet all the criteria for the
Yeah.
QRS widening and so on. But
Yeah.
I'm interested in it partly because one of my classmates has a left ventricular ejection fraction of 28%. It's ischemic cardiomyopathy. He's a professor of surgery in one of the universities. And about 3 weeks ago, he underwent cardiac resynchronization therapy with the pacemaker, the right ventricle, right atrium, and behind the left ventricle. And
Yeah.
he seems to be doing very well, where that is now coming to our next class reunion. So I think that's very helpful.
Yeah.
Okay. One more question, Dr.
The
Ben.
problem with the medications is there's so many
Go
side
ahead.
effects we worry about, and especially when Ben mentioned that's an old study on this, but even Simon Dack, president of the American Heart Association and former editor of the JACC, said that digitalis glycoside is causing more death than suicide because of the iatrogenic effect of some medications. That's all I have to say. Thank you. And that was a very comprehensive lecture, Dr. Lumicao. It would have taken me days to review those data. Now you just presented it in a concise and concentrated manner that I don't have to read journal for a while. Thank you.
I don't have to review my textbook anymore with that lecture on the review. Yeah, I was reminded during my residency that one of the first trials for heart failure is the captopril, the SAVE trial. That made me. It's a landmark trial that made me become a cardiologist because of that one of the trials. I have another question again, Dr. Lumicao.
Yeah.
Now that in the advent of SGLT2 inhibitors, so some of the trials, so in some of the landmark trials of these SGLT2 inhibitors, it shows that there is benefit even without ACE inhibitors or ARB or ARNI. Is it still okay to start straight ahead with SGLT2 inhibitors without these angiotensin blockers? What do you think?
Oh no. I think the ACE inhibitors should be used. I mean, uh, in addition to SGLT2, I think. Well, I you know uh, the leaders say that all four should be used. All
Yeah.
four should be used because their mechanism of action is different. So Actually, the restriction probably will be in the dose. When I said I objected to the poly pill, you are limited in terms of poly pill. You may probably have 2 doses. You may
Yeah.
have too much ACE inhibitor or too much beta blocker. Yeah, don't forget, with the neprilysin and things like that, you also worry about potassium too. Yeah, the renal function and things like that. So I I would I would go for a guided therapy using all four. Okay, but not in a poly pill, which limits your use. Yeah, this is my point. Yeah, but I would use all of them. I would use all of them. Yeah, I still think I still think I emphasized it back in terms of the galactic study. I think I'd wait for that some more, because the lesson, we all are familiar, Ernie, in terms of calcium, calcitropic drug, what in acute intervention, where you on the cath lab you can see benefit, and then mortality statistics said don't use it. Yeah, so the same thing, but this is an entirely different, but the myotropic drugs with omecamtiv. Yeah, so I'm anticipating more news about that. Yeah. Instead of answering question, I have a question for the students and interns listening. I emphasize the fact that the use of beta blockers is associated with 35% on the average of improvement. Why do you use it? You're dealing with reduced ejection fraction. If you have a heart muscle that you suspend in a beaker and you add beta blocker, what happens to contractility? Down, right? So why use it? Tell me. Anybody?
Anyone from the audience? I think you just have to review us again, Dr. Lumicao.
Well, I think the reasoning there is that, as you know, in congestive heart failure with a sympathetic upsurge, you 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 reduce the efficacy of your sympathetic receptors. So you block them so that they will respond later on with contractility. That's the mechanism. Yeah.
Yeah, I can still remember that during my residency days, it's a no-no for us to give beta blockers during the acute phase, or actually even in the chronic heart failure or stabilized heart failure. So it's a no-no. And then until these studies were done on beta blockers, then it's a very shocking landmark for us, landmark trials for us also. Yeah.
Right. Yeah,
I think
35% reduction. That's a lot. Yeah.
yes, it's
Yeah.
very significant. So I think I have another question that was followed. Wait a minute. Okay. Can you comment how much is the success rate of the transplant? Transplant. We in the Philippines, in the 90s we had transplant also. We had 3 patients who had transplant, but they all immediately died within a year or 2. So, and then we stopped on that. I think we're starting again to have a program on that heart transplant. Can you comment on the success rate of heart
Well,
transplant?
well, in the big centers, it's very good response, but it's not the surgical thing that it is. It's the post-op care and
Yes,
things
yes.
like that. Yeah.
Okay. So, but with regard to the destination therapy of the LVAD or BIVAD, can you comment on that instead of having transplant? Is it
Well,
also quite successful?
the, there are stories about some patients getting off the LVAD, because
Wow.
don't forget when they're on the LVAD, medical therapy continues. So yeah,
Yeah.
and with the dearth now of hearts that are available, I think the LVAD is very common. Yeah, yeah.
Yeah. So for everyone who doesn't know LVAD, what LVAD is, it's a left ventricular assist device. So it's a device that will assist your contractility or the cardiac output and ejection fraction of your heart. So I think there's also a good benefit on the LVAD as a destination therapy. So if there are no more questions, are we okay? Can you give us your last message with regard to management of heart failure, or give us the lineup of the heart failure management patient?
Well, I did already. I think there are 4 pillars, the management of congestive heart failure. The most exciting part about it is the SGLT2 inhibitors. We don't know the mechanism, but the interesting thing is that it works whether the EF is reduced or preserved. So this is it, it's a big change in the thinking. Beta blockers, I told you already, is as high as 35% as an average for the use of beta blockers. And of course, the use of ACE inhibitors, and especially with neprilysin, yeah. And of course, your aldosterone antagonists. So all should be used. Of course, there should be care, especially patients with congestive heart failure. Most of them have renal effects. So we have already 2 drugs, the mineralocorticoid and the ACE inhibitors. If you use them in combination, you better watch your potassium, because that can cause you some trouble. So those are one of the concerns I have in terms of the polypill, because I think my big chief went a little overboard when he said polypill. Yeah.
Okay.
So yeah. So I think there'll be more. Like I said, what you heard from me today is obviously not the last word, and there'll be more. There'll be more information that we can use to improve the situation. But in terms of the mainstays in the treatment, we have them there, the 4 pillars in the management. Yeah.
Okay. Thank you very much again, Dr. Ben Lumicao, on that very elegant and
Thank you.
comprehensive talk on the management of heart failure with reduced ejection fraction, and a bit also again on the preserved ejection fraction. Also, thank you to Dr. Ernesto Chua for joining us and introducing Dr. Ben Lumicao, and for joining us on the discussion. So I am honored as a cardiologist to be part of this discussion. Once again, thank you very much for listening to Dr. Ben Lumicao and for listening to our discussion with regard to heart failure with ejection fraction. Thank you again.
Ernie, thank you.
Thank you.
So we now go to the awarding of certificate. May I have Dr. Abby?
Yeah, so the UERM MMC College of Medicine awards this certificate of appreciation to Dr. Benjamin G. Lumicao, FACC, FACP, for invaluably sharing his expertise in the 8th Dr. Wilmer G. HECETA Memorial Lecture entitled Current Management of Chronic Congestive Heart Failure, given this 13th day of December 2021 at the UERMC's MMCI, Aurora Boulevard, Quezon City, Philippines. Signed by President Esther Garcia, Dr. Hemiliano D. Aligue, Vice President for Academic Affairs, Dean Norbert Lingling D. Uy, Dean of the College of Medicine, Dr. Vina Marie Tenorio Quinones, College Secretary, College of Medicine, and yours truly, Abigail J. Chong Rivera, Chair of the Committee on Special Conferences. Thank you very much, Dr. Lumicao, and Dr. Chua for joining us.
Thank you. Are we gonna hear from the family of Wilmer, Dr. HECETA?
So now let's all welcome Dr. Esther Bell HECETA for their response.
Dinoy, Dr. Chua, Dr. Lumicao, Dr. Garcia, and Dr. Rivera. I would like to give a special thank you for your continued support of our beloved alma mater, the UERM MMMC. I am Dr. Esther Bell Aguilar Hecetta. You can call me Bell for short. I would like to thank you very much for giving me the opportunity to give the family response to the 8th Dr. Wilmer G. HECETA Memorial Lecture, which was given by our good friend and classmate, Dr. Ben Lumicao. Before I proceed, I would like to give a short history of how this memorial lecture came about. This lecture was first initiated by UERMMMC class 1973 with the blessing of the Alumni Foundation of USA. In the early days when this lecture was still being talked about, Dean Retta wrote, "I hope we are all in support of such a worthwhile endeavor as our gratitude and tribute to a great man who has served as a source of inspiration, as a mentor, and as a respected role model to the alumni for his loyalty, dedication, gratitude, commitment, and unrelenting efforts to help the medical center in general, and his efforts to strengthen the faculty and student development programs." So to honor him, first, I would like to share with you some representative photos that speak to who Wilmer was, and then I will speak to how you can carry on the legacy of my late husband in honoring our alma mater, UERMMMC. To begin, this picture was taken in 2007, which was the second to the last reunion that Wilmer was able to attend. At this meeting, he was awarded the Outstanding Leadership Award in Medicine by our alma mater. Our alma mater means so much to both Wilmer and I because it was not only the place where we studied medicine, but it was also where we met. In fact, we were classmates in all 5 years of medical school, and he would go on to graduate at the top of our class in 1961. We were the first graduating class of UERMMC, and in that class, 3 of the top graduates were awarded the distinction of cum laude. That was Wilmer, myself, and Rogelio Locas. Soon after graduation, Wilmer and I got married, and a year after graduation, we came to the United States for our residencies in surgery and anesthesiology, respectively. We were married for 40 years and have 3 professional daughters and 5 grown grandchildren. After our residencies, we made our home in Wheeling, West Virginia, where Wilmer and I practiced for medicine for more than 30 years. He in surgery and I myself in anesthesiology. He was a board-certified general and thoracic surgeon, while I am a board-certified anesthesiologist. As devoted as he was to his work, Wilmer was even more faithful and devoted as a husband and as a loving father. This picture shows Wilmer and myself with our 3 daughters during one of our summer family vacations quite a few years ago. The oldest, Chris, has a BA and an MBA in finance and accounting, and is presently the Director of Financial Consolidation and Reporting at Mindstream Analytics. Elgin, our second daughter, is a lawyer and practices law in Wheeling, West Virginia. Wella, our youngest daughter, has a BA in psychology and currently works as a wraparound facilitator for Bradley Thompson and Stepson Youth Services. Wilmer was also a doting grandfather. Although this portrait was taken quite a few years ago, it is the last one where both Wilmer and I were in the picture together with the grandchildren. The grandchildren have grown quite a bit since then, and 4 of them are holders of bachelor's degrees, 2 with master's and 1 with a medical degree. Danielle, who is 29, our eldest granddaughter, has 2 bachelor degrees, an MBA, and is presently pursuing a PhD in sports management at the University of Massachusetts Amherst. Ian Wilmer, now 27, graduated at the top of his class in chemistry as a summa cum laude, and then proceeded to go to medical school. After his MD, he began and is still currently pursuing residency in anesthesiology. Our 3rd grandchild, Tyson, has an undergraduate, he's 24 years old, and has an undergraduate degree in psychology and a master's in higher education. At present, he is working as a basketball video scout for Sports Solutions. And Brooke, 22, now is our 4th grandchild, and she is a senior at Elmira College, majoring in accounting. Braden, who is 22 now, is our youngest granddaughter. She finished her BS in psychology within 3 years, and she graduated as a summa cum laude. Presently, she is working as a behavioral health technician. The next picture showcases an invitation for the last birthday party that Wilmer celebrated. While there were many things that made Wilmer unique, I don't think many people know that Wilmer was a leap year baby. He was born on February 29, 1936, and would only celebrate his birthday every 4 years. On February 29, 2008, Wilmer celebrated his 18th birthday in Wheeling, West Virginia. You will notice that on the invitation it states that he reached the age of majority. This was the last birthday that he celebrated, and how fitting that this celebration was his 18th birthday. This was his last, as his 19th birthday would have been celebrated on February 29, 2012. However, Wilmer passed on January 23rd, 2012. Though he passed before his 19th birthday, he lived a full life. While Wilmer was here, he touched so many lives. One of those whose life he touched wrote a poem that spoke to how he had touched their life. I'd like to share this poem with you. It is entitled To Honor Wilmer G. Hecetta. He can make light of our weaknesses because he recognizes them in himself. He can laugh with us because he can laugh at himself. He can trust in our strengths because he knows they are in each of us. He can play with us because he's retained the joy of a child. He can understand us because he's wise in the ways of human nature. He can help us because he'll give his all. He can ask anything of us because he knows he expects it of himself. He can inspire us because of his own example. With a laugh, he often hides his own pain, but brightens the day for others. With caring that comes from within, he soothes and heals. With his loud voice, he makes us listen. With competency and outstanding ability, he practices as a physician. With his hurry-up approach, he gets the job done. With wisdom and empathy, he explains hard realities. With his teasing and kidding, he's always noticed. With support and hope, he's standing to the end. With dedication, he accomplishes what most men never dare. With love for all people, he serves tirelessly and endlessly. He can lead us because he is Wilmer G. Hecetta. Friends, truly Wilmer led us while he was here. Wilmer led us with his great commitment to our alma mater. Often he would spend his spare time trying to think of ways to help our alma mater. It was the strong feeling of gratitude to our medical school that motivated Wilmer to give something back in return. This is how he got involved in the Alumni Foundation or AFUSA, but his involvement with our alma mater was not limited to that. Wilmer and I contributed to book scholarships, professional chairs, and much needed equipment. In times of natural disasters that affected the medical center, Wilmer was very generous in donating money. After Typhoon Ondoy, where the medical center was flooded again, he donated his whole month's SSS check to the relief fund. And long before that, he also bought a life insurance policy with Afusa as his beneficiary. It was also out of his desire to give back to UERMMC that Wilmer introduced the concept of the 333 Fund in 1995. His idea was that it would be easier to request $333 from a donor every year for 3 years to make a total of 1,000. All donations to this fund are deductible, tax deductible, and since the fund is an endowment, the principal is always intact. It was Wilmer's dream to get this fund to a total of 100,000 by 1999. Unfortunately, Wilmer did not see this happen while he was here. This goal, however, can be realized even if only 1,000 alumni respond to the appeal of 333 per year for 3 years. It behooves all of us to donate to this fund and to continue giving, so UERMMC will remain as one of the premier institutions in medical education and healthcare in the Philippines. I challenge you all to join me in following Wilmer's lead one last time by contributing to his 333 fund that supports our alma mater. Thank you. God bless you, and may God bless UERMMC.
May we now hear the closing remarks from the president of the UERMMCI, Dr. Esther Garcia.
Good morning, everyone, and thank you for inviting me to this lecture in honor of Dr. Wilmer Hecetta, one of the UERM pioneers. I would like to congratulate Dr. Benjamin Lumicao for sharing his expertise with us this morning. Thank you, Dr. Lumicao, for discussing the management of heart failure. The last known data on congestive heart failure in the Philippines showed a prevalence rate of 1.6%, or 1,648 cases for every 100,000 patients. Congestive heart failure consisted about 22.67% of the cardiovascular-related hospitalization claims with PhilHealth. As is the trend worldwide, we expect the prevalence of heart failure in the Philippines to rise. Not too long ago, the diagnosis of heart failure was dreadful because its prognosis was poor. The mortality rate of patients with heart failure was 50% within 5 years. Your lecture today painted a brighter future for patients with heart failure. With the new medicines and device-based interventions, we are better positioned to help heart failure patients. We can improve their survival, decrease their hospitalization rates, and improve their quality of life. Like Dr. Wilmer Hecetta, your passion for pursuing things that will improve the lives of others is well known to all of us. Dr. Hecetta started the 133 movements among our alumni in the USA that aim to generate funds to support the programs of your alma mater. You have recently pledged a substantial contribution to the Study Now, Pay Later program of the College of Medicine to help needy students pursue their medical education. The endeavors where the two of you consecrated your lives are indeed worthy of emulation. Our faculty and students should stay inspiration in your relentless pursuit of the vision and mission of our institution The UARM takes pride in having you as one of our alumni. Congratulations to Dr. Lumicao and the Alumni Association. Again, thank you.
Please remain online as we listen to our UERM hymn.
Oh, UERM Medical Center.